with politics. It has to do with what's happening in the community and where we can be helpful. We're so lucky, so fortunate tonight to have Dr. Magadia with us. He's on call if you had to check into that hospital and it was a critical situation. He's the one you'd face. I see Dr. Mike Hanna over here. This is a critical time that we're in, and so it's good to have someone who knows what they're doing, who can give us some good information and can give us tips for what we can do to be helpful to our friends and neighbors. If you need a mask or if you need anything, we have plenty inside. Here's a nice little plus to this, and Dr. Magadia doesn't even know it, and he hadn't even spoken his first word. But we've been given a $250 check tonight by an anonymous person in honor of Dr. Magadia. Let's hear a hand for it. My name is Sheila Gilbert. You want to do that for me too? Actually, we love being in this community. We love working here. And you know, it's such a natural place. You hear the cars going up and down the road. You see Noble Street over here. We're right in the heart of what's happening in Calhoun County and in Anniston, Alabama. And when a crisis hits, we like to all do what we can to help to make it a better situation. So with that being said, I will turn it over to Dr. Magadia, the infectious disease expert at RMC, who's given his time to try to step outside his busy zone and help educate and talk about things that are very, very important and answer some questions. I see we have Representative Barbara Boyd here. How pleased we are. Hold your hand up, Barbara. Let's give her a hand. Thank you, Barbara, for being here. Are there other elected officials? All right. Dr. Magadia, it's my absolute pleasure as the chairman of the Calhoun County Democrats to welcome you to this wonderful site.
Pleasure's mine. Good afternoon. Like Sheila said, I'm Dr. Magadia. I'm the infectious disease specialist at both hospitals, RMC and Stringfellow. I'm the chairman of the Infection Control and Prevention. I'm also the director of the Pandemic Response Team, which is a team that was actually created specifically for this pandemic that started last year. So welcome, thanks for having me. This is a lecture on gonorrhea. No, it's a different crowd. So this is a talk. If this is informal, please free to stop me if you have questions. I'm not gonna lecture you. We're gonna just tell you our local personal experience since March of last year. So that being said, since March of 2020, we have had close to 1,200 patients that we admitted to the hospital. We started late March of last year. Coincidentally, our very first confirmed COVID patient was a registered nurse who got exposed in one of the known local outbreaks in town, in the clinic. And she luckily got better, but she was our very first patient in March. We didn't really have much patients during the subsequent months. We had a lot of problems with testing back then. I'm sure you guys are familiar with the term PUI, or person under investigation. We had a lot of PUIs back then because we were sending our specimens to Huntsville, Tennessee, Birmingham, sometimes in Atlanta. So it was taking us about 2 or 3, sometimes 5-7 days to get the confirmation that they have COVID or they don't have COVID. So in the meantime, the COVID ward was filling up, not necessarily with COVID patients, but the PUIs. And through April, May, and June, we had few spotting cases. And I'm going to have Kristen here come forward and show a graph that I have here. The graph up top is, the blue graph is the admission, and the bottom is the deaths. So our first spike really started in July, kind of mid-July, and that was brought on by the 4th of July weekend. So that July, we had a lot of experience with people sick. And in August of that year, we saw a lot of deaths from that 4th of July crowd. As a matter of fact, that there's a 12-day period in July that we had 15 deaths. So we were seeing about 1.2 deaths a day. It was kind of tough for us, healthcare workers, including myself, physicians and nurses, seeing, you're coming in at 6:30, 7 o'clock in the morning, and as you are entering the ward, the guy from the funeral home is rolling out a dead body every single day for 12 days. That was rough. And we kind of survived the subsequent months, and we saw a spotting of cases in October, November, but our biggest spikes was really truly in December and January. That was brought on by back-to-back holidays, the Thanksgiving, the Christmas, and New Year holiday, which was aggravated by the weather. So that, the flu season came in, and that particular weather was conducive to indoor gathering. Speaking of influenza, or the flu season, just a side note, in 2019, in December of 2019, we had, the whole of 2019, we had about 292 people who got hospitalized because of the flu. So these are people who had flu bad enough that they needed to be hospitalized. I'm not saying that the whole 2019 we had only close to 300. These are people really sick enough, they're throwing up, they're having fevers, they might have concomitant bacterial pneumonia, and all those things. We had in 2019 about close to 300, 292 to be exact. The whole of last year, 2020, we had 8. So from close to 300, it went down to 8 cases of influenza needing to be hospitalized. So that tells you 2 things. One is people were listening to us back then, because in summer of last year we were saying this is going to be bad, get your flu shot, because we don't know what's going to happen, it's going to hit us. So we were able to convince a lot of people to get their flu shots, vaccine. The second thing was masking. So everybody was masking. I'm sure you guys are sick and tired of the term social distancing. So everybody was 6 feet apart. They forego vacations. They forego visiting their cousins, their family members. They forego visiting their friends. So that, in a way, helped the flu. But since we have not seen this particular virus, which we call SARS-CoV-2, our body was totally naive or not immune to this virus. We still had a lot of cases in December and January. On down below is mortality. So we had our first deaths in April. We had several deaths in August. Like I've said, we had 15 deaths in 12 days back then. But our deadliest month was January of this year. We had 44 deaths. And that, again, like I've said, is brought on by the back-to-back holidays and the weather. And something happened here in February, March. Anybody would like to venture a guess what happened? Vaccine. We did not find a cure. We did not discover a magic potion or elixir. Nothing like that. We just started vaccinating people. And we started with people who might be at risk based on their physiology, 75 and above. You remember the tier system that we had back then, tier 1A, 1B, and you were waiting. And actually, as a matter of fact, I witnessed, I saw a long line at the Anston Meeting Center. Those were good times. So people were lining up, the 75 and above. People with diabetes, regardless of their control, people with kidney problems, and the cases plummeted down. both admissions and deaths. So we, in a way, we celebrated some right around here in June, July, but something happened here again. It started creeping up. This is middle of July. I don't have data from August, obviously, but something happened here. You know what happened?
Did they get their shots?
So a lot of people, a lot of those old folks got their shots, but we had a lot of holdouts. We had what we call the vaccine hesitants. So that happened. What else happened? Delta happened. So 3-4 weeks ago, Delta was not a term that we use every day. Nobody actually knew, or very few people knew about Delta. But Delta happened here, sometime in July. So Delta, briefly, Delta is a variant strain. It's a mutated strain that was first described in India. And you guys know what happened in India 2 months ago. It just ravaged the whole subcontinent to the point that I think officially they had almost close to half a million deaths, but unofficially they think it might be close to 1.2 million because a lot of people were just dying at home. And since it's a predominantly a Hindu country, they were remaining their folks even prior to them going to the hospital. So it burned that country, and somehow it made its way into the rest of the world, including us. So in July 20th, 3 weeks ago, we reported our first case of Delta in hospital. For purposes of HIPAA, I'm going to use the non-binary pronoun they. So they came to us 9 days into their symptoms, and the symptoms were described as a lot of GI problems, throwing up, diarrhea, and those symptoms started about 4 hours after exposure. So you're familiar with incubation period. Incubation period is the period wherein the time from your exposure to the onset of symptoms. What we know about COVID-19, the original strain of SARS-CoV-2, was the incubation period is somewhere between 7 to 14 days. So on average, it's about 6 to 7 days. So you get you get exposed to somebody at Walmart or whatever. You don't really necessarily get sick right away. It takes about 5, 6, 7, maybe 8 days before you get the symptoms. With Delta, it's totally different. So this particular person, they got sick within 4 hours. So we think it might be related to the transmissibility of the virus. So Delta, they said, has 3 mutations. Those mutations make it more spiky and it's more transmissible. Therefore, it takes few minutes, few hours, maybe few days for you to get infected and develop symptoms. So anyway, they came to us 9 days having nausea, vomiting, diarrhea, and by then they were getting dehydrated. They were really struggling to breathe. They had a positive COVID testing at the local urgent care. When they came to us, we did 2 testings. One is a rapid antigen testing, which takes about 15 minutes. And the second testing was a PCR, which takes about 90 minutes or about 2 hours. Both of those testings came back negative. So we had a high index of suspicion that we're dealing with somebody with COVID, probably Delta, because of the rapid onset of action, or rapid onset of symptoms. And based on the X-ray, based on the labs, and you're sure you're familiar with the saying, if it quacks like a duck, talks like a duck, it must be COVID or Delta. But anyway, so we had that suspicion. So we sent another specimen to Tennessee in Memphis. Yes?
Does that mean all ducks are COVID?
It might very well be. Yeah. Or Delta. Delta for ducks. Okay. So anyway, we sent another specimen to Memphis, and within 2.5 days, it came back positive. I remember it vividly because they called it at 11 o'clock that night that they had the Delta. We just had that suspicion that they had that Delta, so they stayed at the COVID ward. So there was minimal interaction with the staff because if you have 2 negative testings in the hospital, even one, depending on your presentation, we send you to the non-COVID ward. But we had that clinical suspicion that they had the Delta COVID, that we just kept her at the COVID ward. Yes, ma'am.
At a local level, can the testing determine whether it's the Delta variant or Lambda or whatever?
So the question is, if the usual testing that they do here locally, either the rapid testing or the PCR testing, can you differentiate between the original strain, the wild type strain, versus the other strains, alpha, beta, delta, gamma, lambda, epsilon? No, you cannot. The PCR testing or the RNA testing will tell you that they have COVID-19, but it's not going to differentiate between a regular strain and the variant strain, because most of the labs that we have, or all of the labs that we have locally, including the hospital, we don't have a way of doing what we call genomic sequencing. Genomic sequencing, they do further analysis for mutation. So when they see mutations, at least 3 mutations, they will know that this is not the original strain. So we don't have that capability. So anyway, they progressively got worse to the point that they had to be put on ventilator. And unfortunately, they passed away this past weekend. So fast forward August of this year. August of last year, we had 15 deaths in 12 days. This year alone, for the past 11 days, we have had 16. So we broke that record from last year. Prior to Delta, the deadliest most 24-hour period that we had was back in January, when we had 3 deaths in 24-hour period. That was rough. You know, your patient dying on you, 3 patients of you dying on you within a 24-hour period, that's really tough emotionally. Tuesday last week, we had 4 in a 24-hour period. And we said, this is really bad. This past Saturday, we had 7 in a 24-hour period. So for 11 days, up until yesterday, we had 16 deaths. When I came in this morning, the nurses said, hey, Dr. Magalia, we had 0 deaths for overnight, which is really a kind of messed up way of saying good morning. That's how they treated me this morning. We had 0 deaths this overnight. It's a celebration. It's a minor victory for us that nobody died on us overnight. So talking about Delta, the way that we treat Delta is kind of no different that we treat the original strain. We give them fluids, we give them multivitamins, we might give them antibiotics depending if they have concomitant bacterial infection. We give them steroids, we give them oxygen. It's no different. It's just that, we have to know that, so that the way that we isolate them is different, because we cannot send them to a regular non-COVID ward if they have Delta. The vaccination happened. We think that the Delta strain will still be, the vaccination will still be effective against the Delta strain. The problem is there's a lot of those holdouts. We call them vaccine hesitants. They're not completely opposed to vaccines. They have questions, and they're holding off because they had bad experience with the flu. They had a cousin who had some kind of neurologic condition. We just have to reach out to them. And that's about 40% of them. Currently, we are sitting at about 33% vaccinated in Calhoun County. And I'm gonna segue this to a sexy term called herd immunity, HERD. herd immunity is a term that a lot of people were throwing because that's the only way out of this pandemic. We get to that level that everybody is vaccinated, everybody is that immunity that it's not quite 100%. When we first started this pandemic, it kind of sounds like we have two pandemics. The first pandemic is last year, the pandemic of the regional strain, and right now I think Governor Ivy said it correctly when she said this is the pandemic of unvaccinateds. So it looks like that majority of the people that we have currently, we have about an hour ago when I made rounds, we're sitting at 48 patients in-house, including the ER holding. 4 of those 48 were completely vaccinated or fully vaccinated. So we're looking at maybe 92%. 92% of the people in the hospital are not vaccinated. So every time I talk to family members or even patients about that, I said, this is really a compelling evidence that the vaccine works. The reason why you're here is you're not vaccinated. I might have some people that I was able to convince, but some people just say, this is nothing. I'm still not gonna get vaccinated. So those vaccine hesitants, there's about 40% of them. If we could reach out to them and somehow convince them, because right now we're sitting at 33%. If we could convince them, we're about 40%. We're gonna be at 73%. The herd immunity that the number that they threw last year, the first pandemic, was about 70%. Delta happened. It got raised to 90%. So 80 to 90% is the herd immunity, the bar that we have to scale for us to get the herd immunity. So if we get that 40% vaccine hesitance, we're closer to 90% than what we are right now. We're sitting at 33%. The 15% of people, no matter what you do, they're holdouts. They're anti-vaxxers for a variety of reasons. Personal, professional, financial, religious, and even political reasons. You're not going to be able to convince them. But the 40%, we should be able to capture. That's why we're, Kristen and I, Kristen from marketing, RMC, say hi. We're doing these rounds. This past weekend, we hit 2 churches. We had a Chamber of Commerce this morning. We did Kiwanis last week. We're trying to reach out these small groups because you have the power to convince some other people as well. So if we could do that from your end, obviously I cannot do this by myself. I have Dr. Free and Dr. Patel also doing this. So we're going to these small communities, small groups, trying to convince people and tell them about the vaccine. Yes, sir.
How long do you expect vaccine?
All right, excellent question. The question is, how long does it last, the immunity that you get from vaccination? So I think you're leading towards the question about booster. And it's a booster shot. When do we get it? So in about 1 or 2 weeks, CDC and FDA will come up with a recommendation about giving boosters to the high-risk population, the 65 and above, diabetics, regardless of their control, kidney problems, heart problems, people with cancer with or without chemo, HIV/AIDS. Those are the ones most likely by the end of the month or in September that will be given booster shot, regardless of whatever you took, either Pfizer, Moderna, or J&J. The recommendation for the rest of the population, 64 and below, non-diabetics, will probably come towards the end of the year. That being said, it's looking like this is something that we will be doing every year. There's already trials going on for combining the flu shot, which is every year, and the COVID shot. So most likely, this is something that we'll be doing. Excellent question. Yes, ma'am.
There's a lot of news about the hospitals becoming overcrowded. crowded and not having the capacity, how are we here at your hospital with as far as handling the number of patients that we have?
So the question was, how are we as the hospital in handling the volume of COVID patients? So last week we had one COVID-1, which could accommodate 22. That's the highest. And we had a lot of, towards the middle of last week and towards the end of the last week, we had a lot of patients waiting in the ER. So we had to open another ward called COVID-2, which could also hold 22 patients. So that's 44. We have a holding area in the emergency room that could hold somewhere from 10 to 12. If we reach that capacity, so 44 plus another 10, so if we hit more than 55 or 60, we probably don't have a choice but to open another ward called COVID-3, which we did in December, January. We had 3 COVID wards that house all those COVID patients. It's kind of hard to predict because Delta is so, number one, it's so hard to predict, period. Number two, it's so contagious that it's just ravaging it. Number three, it might be deadly. So like I've said, the 16, last week, or for 11 days, we were able to discharge 16 patients by way of funeral home. That's not the way we want them to be discharged. So it's so deadly, we think, that we're leveling off at around 44, 48 patients right now. It might be different tonight. So we're still holding on. The problem, which is the same universally all over, is staffing. I make rounds every day. I see almost everybody every day. I go in the room, talk to them, see them, maybe 5-10 minutes. And I go to my little tiny room there and write my notes and put my orders. The nurses, they're in the room the whole time. And if you are a nurse taking care of a patient dying on you every single day, it's a hard pill to swallow, pardon the pun, because you're having to hold their hands, you're having to call their family members. I'm sorry, your mom just passed away. It's hard, and they show up. These nurses show up, but it's hard on them. I might be the face of Dr. Free, Dr. Patel. We might be the face of COVID in the hospital, but these nurses, they're the heart and soul. I don't know how long they could handle this. Currently, we have a lot of what we call travel nurses. So these people are from California, from New York, all over the place. They're getting paid good money, but money is nothing if you're having to deal with all those things emotionally. Yes, Dr. Hannah. I wish you. It's 44. Yeah, 44% of our healthcare workers are not vaccinated. Yeah. So the problem with healthcare workers we're dealing with, I've actually been personally dealing with that. I proposed 2 things in the hospital. One is we have a kind of doctor's lounge there. You could go in and out. You swipe your badge, and you go there. There's a coffee, $5,000 coffee machine. There's food there. There is a fridge that you could get water and drinks. So my proposal, a month ago was, if you are able to go to a physician's doctor's lounge, these are doctors and mid-levels, nurse practitioners, nurse anesthetists, some other members of the administration, and you are not vaccinated, we will ban you from that, from going in there. So you cannot get coffee, you cannot get the buffet and all those things, breakfast and lunch. I had a lot of rough, angry phone calls the first few weeks, but I said, tough luck. If you're not vaccinated, you're not in the list, we will ban you. So I had help from IT. So we banned them from, I said, I'm not going to be able to, I'm not sitting with you in that little tiny room if you're not vaccinated, you're eating the same food that I'm eating. So I'm not going to be able to sit with you. So we banned them from that. So hopefully it picked up. The second thing, let me just finish. The second thing that I proposed 2 weeks ago was those healthcare workers, nurses, techs, working in janitorial services, and if you're not vaccinated, about 44% of them, you will be required to wear N95 mask, not just a regular surgical mask, which is easy to pull up and down. The N95 mask is the bulky mask that you see, one that you have. Can you stand up? Hey, a model. Okay, the N95 mask, you have to wear that regardless of your assignment, whether you're doing direct patient care, or you're doing billing, or you're just mopping the floor. If you're not vaccinated, you wear a mask. Number two, you might be subjected to weekly COVID testing. I don't know if you guys have had COVID testing before. That's the closest thing that you could get in, like, brain biopsy. They're literally shoving that thing all the way up to your brain. It's not pleasant. So I propose that I got some kind of lukewarm response from everybody, because they said it's gonna turn them off, and they might go to Gadsden or Tanner. I said tough luck. So I'm still pushing for that because it's really something that we have to do with healthcare. It's a problem with us. I know there's a lot of bigger hospitals, including Houston Methodist in Texas, that had, as of June 7th of this year, if you're not vaccinated, don't show up. Yeah. So there's a lot of hospitals doing that. The problem is, this is small town Anniston, Alabama. So if we institute that policy, we're gonna lose 40% of them. They're gonna go to Gadsden, they're gonna go to Tanner, unless everybody does it, the whole hospital, and they have no choice. Yep. If that happens, I'll be a happy clown. Yeah. Yes, sir.
My question is about masks now. The best I can understand, whether this is right or wrong, is that the main reason for a person who's fully vaccinated to wear a mask now is to protect people who aren't, statistically. Am I right about that? And what protection does it give you?
So yeah, you're right about wearing masks although you're fully vaccinated. The other reason is the vaccines currently available, all three, Pfizer, Moderna, and J&J, they are what we call disease-modifying vaccine, meaning it modifies the disease. You might still get the infection, but you're going to get a mild to moderate disease. So it prevents you from getting severe to critically ill type of infection. It's preventing you from ending up in the hospital. It's preventing you from seeing me. It's preventing you from ending up in the ICU. It's preventing you from dying. But those vaccines do not prevent you from having mild to moderate, a little bit of achy, a little bit of runny nose. So although you're vaccinated, it's not 100%. It's not a transmission blocking vaccine. The transmission blocking vaccine is polio. So, if you take the polio, the oral polio, you're not gonna get polio, period. But the problem with polio, it's a live vaccine, meaning it's a live virus. Nobody's doing live vaccine clinical trials right now for obvious reasons, because it's a pandemic. It's unethical to do a live vaccine clinical trials right now. So you still need to protect yourself with wearing masks. The second reason is you might transmit it to somebody else. So let's say you have two people that got exposed. One is vaccinated, the second is unvaccinated. Of the two, both of them will have the virus in their nose. The unvaccinated ones will shed the virus maybe for 3-5 days. The vaccinated ones will shed the virus maybe half a day or a day. So the way that your body will react if you're vaccinated, it's much quicker if you're vaccinated. So you're going to be able to get rid of the virus compared to unvaccinated ones. So you're still risking your loved ones, although you're vaccinated with this, especially with the Delta. Yes, ma'am. They were not. Yeah. Yes, sir.
So if you took the J&J as your vaccine, would you change up to Pfizer and Moderna?
So that question is, if you have gotten a J&J vaccine as a booster, are you going to get a different platform? So there is a crossover study in both the UK and Maryland specifically studying that. And according to that side, I think it's only like 200 patients. But according to that study, those two studies, it's safe to cross over. It's actually, as a matter of fact, physiologically, or if you really dial into the immunology, it's probably better that way because it's two different platforms, two different mechanisms. So the Moderna and Pfizer, they're mRNA. And for J&J, it's a vector-borne, it's adenovirus, meaning the common cold virus is like a Trojan horse. So it's a different mechanism. So you're tricking your body into saying, oh, I need to produce much more antibodies because this is different. So it's looking like that you could cross over.
So I had a friend
So the antibody testings that currently available right now, it tests for the presence of antibodies, and there's a numerical value that they say. All the currently available antibody testings for COVID-19, they are not standardized, so we don't know how to. And actually, as a matter of fact, on that paper, it will tell you we don't know how to interpret it, and use caution in interpreting these numbers. Nobody knows what it means. Yeah. We don't know what it means. Yeah, it's not like I don't know. Nobody knows. Yeah. Yes, ma'am.
Where are we with being able to administer vaccines to under 12?
Excellent question. So currently, the only people eligible for vaccine is the 12 and above with Pfizer, and 18 and above with Moderna and J&J. There was a study that was actually submitted to FDA a few weeks ago by Pfizer for 6 months and 11. They had 545 volunteers. Imagine a mom volunteering at 6-month-old. Kudos to that mom. Yeah. Well, and according to that study, it's 100% effective, 100% safe. The FDA, they have a lot of plates in their, they have a lot of things in their plate. They have a lot of plates in their table. You know what I mean. And they're doing a lot of, studying a lot of clinical trials. So it was submitted. So maybe the recommendation for that is sometime, maybe in the fall, to vaccinate the 11 and under. Because that's another, maybe another 15-20% that we could get. So it's probably looking like it's going to be a universal vaccination, like Hep B and MMR and DPT. Yes, ma'am. So the question was, when are we going to finally say that all the vaccines are officially FDA approved? Right now, they were granted what we call EUA, or Emergency Use Authorization, which is the last step before they officially get approved. Prior to this pandemic, the fastest that any vaccine was approved was 4 years, mumps and Zika. There was no pandemic of Zika, there was no pandemic of mumps, but we're dealing with a pandemic, second pandemic. So they're thinking that, the final approval will be coming soon. I don't know, they keep on saying the word soon. On the federal level, I think there was some kind of executive order from the president wherein they will require all the military personnel to get vaccinated. So that will be, you kind of have sense that the formal approval will be coming soon, because from the president, he said that if you're military, you're going to be required to get the COVID-19 shot. So it's coming soon. I just cannot tell you the time frame. I wish I could tell you 2 weeks, 3 weeks, but it's within this year. Yes, sir.
Could you talk about the efficacy of masks given the microscopic size of the virus?
So typically the question was the masking and the microscopic. So the SARS-CoV-2 is 0.9 micron. The mass could only accommodate like 1 micron. But that surgical mask. But the good thing about surgical masks compared to regular cloth masks, they have multi-layers. So although they have bigger holes relative to the virus itself, you have at least 3 layers there. So the virus does not have a pair of scissors. When you inhale them, they're not gonna go in there and cut. So once they encounter the first layer, they might be able to get through the first layer, but you have second, third, fourth layer. I have now resorted to double masking. I did not do this. I was doing this during the January, December surge. I stopped doing it after that, and I'm back maybe for the past 3 weeks double masking because of Delta. Yeah. Yes, ma'am. Hi, Dana. So, the question was, what about face shields? So the face shield protects you against a direct hit of the virus. So when you get sneezed on, it has a direct hit to your nose and nostrils and your mouth. But you never know if they'll hit you from the side, from below, from this side, or even up front. So although you see a lot of people, and as a matter of fact, I did that also back in July of last year, we still recommend that you wear a mask. One single mask plus the face shield. The rare times that I traveled by plane in September of last year, I did 2 masks, one a surgical mask, one N95, and a face shield, because I was in the plane for several hours. So I think those scenarios wherein you cannot really social distance and you're stuck in that room for a long time, I think it might not be a bad idea to use face shield with the face mask. But we don't, in the hospital when we see those COVID patients, we have PAPRs or those respirators. We literally look like astronauts. We have the little tiny respirators there. So we're all geared up. So there's no way for the virus to go in and out.
I have a Facebook question.
Facebook question.
For Nancy. Nancy Lumsden said, if you have COVID, how long after before you get the vaccine? And if you have antibodies, should you still get vaccinated?
So the first question is, if you have had the COVID, how long does your immunity last, and when can you get the vaccine? And the second question was, what was the second question?
If you have antibodies,
if you have antibodies, like what Tim asked. So prior to Delta, what they recommended was 90 days. So if you have had the COVID, your antibody lasts for about 90 days, so 3 months. So prior to Delta, they're recommending you can get vaccinated as long as you're not having any more symptoms after 3 months. Delta came, so that changed if you look at the CDC website, they're kind of flip-flopping. They said that as long as you're not on quarantine anymore, you're not having any symptoms anymore. So the only thing that I could see was 4 weeks. So during the Delta pandemic, if you have had the COVID, and we tell this to our patients, you wait 4 weeks. So if you have antibodies, for whatever reason you had it tested, since, alluding to the question of Tim earlier, we don't know what it means. So number one, we don't recommend that you get antibody testing because it's not standardized. Number two, since nobody knows what it means, you don't know if you're really protected. So the only reason by which you would get antibody testing is if you're involved in clinical trials, doing serosurvey for epidemiologic purposes. But outside of that, you're just wasting $50 because that's how much it costs.
I guess the better question is, if you've had COVID and you think you have antibodies and you think you're immune to it, why should you still get vaccinated?
Because of Delta. Because you might be protected against that particular strain, whatever, alpha, beta, but you're not protected against Delta. So everybody's talking about Delta, right? Delta has 3 mutations. Those mutations make the Delta more transmissible. Nobody's really talking about Lambda. Lambda, we're on the L now. That's a Greek alphabet. Lambda has 5 mutations, including the 3 mutations that Delta has, makes it transmissible. There's 2 extra mutations. Those 2 mutations make it resistant to the vaccine. So think about that. So the sooner that we stop them from multiplying and mutating, the better for us. Hopefully we stop at Lambda or Mu. But there's all the way to Zeta. If they go to Zeta, they go back to Alpha again, or Alpha, Alpha, Delta, Delta. So the sooner that we get people vaccinated, the sooner that we could stop this chain of mutation. There's no real medical reason for you not to get vaccinated. There's actually 2. I could think of 2 reasons why you cannot get vaccinated. Number 1, you're allergic to the components of the vaccine. For Pfizer and Moderna, they're inside the vaccine, there's mRNA. Outside, there's a casing called PEG, or polyethylene glycol. If you're allergic to polyethylene glycol, nobody's allergic to RNA because we have DNA. So if you're allergic to polyethylene glycol, you cannot take Moderna and Pfizer. You know what polyethylene glycol is? Miralax. If you're allergic to Miralax, you cannot take Moderna or Pfizer.
I'm allergic and gives me diarrhea.
Good one. I have a joke about that. Have you seen the movie Constipation? You haven't, because it has not come out yet. So if you're allergic to polyethylene glycol, you cannot take Moderna and Pfizer. So you could take J&J because it's a vector vaccine, so it has that Trojan horse. But outside that casing, there's a product called cyclodextrin. You know what cyclodextrin is? Febreze. So if you're allergic to Febreze, the laundry deodorant, the one that sucks out the odor.
Yeah.
Cyclodextrin does that. If you're allergic to Febreze, you cannot take J&J. You have to take the Moderna or Pfizer. So those are the one reason you cannot take the vaccine if you're allergic to the component. The second reason is if you have had this rare neurologic condition called GBS, or Guillain-Barré syndrome. It's a rare neurologic condition wherein after vaccination or a viral kind of infection, you have what we call ascending paralysis. You get paralyzed in your toes, your knees, your hips, and things like that. It's very rare. If you have had that 20 years ago, you might still get it, but you have to talk to your primary care doctor or even neurologist with that. If it's within the past 2 years, probably vaccines are not for you. You're probably going to have to hold off. Only 2 reasons. Allergic to the component, whether it's the Miralax or the Febreze, and the GBS. That's it. Yes, sir.
Don, I got 2 questions. One about the worsening of the disease concerning diversion from the hospital to other hospitals. And how will that decision be made? I think you've already touched on it, staffing problems, things like that. But can you just tell us, because as a local community, I think that's a leveling up of the problem, and we know it can't be seen. And another question is the end of this. For those of us that have businesses, schools, churches we're in charge of, and we're trying to do virus mitigation things, what would you be looking for? Is it the transmission rate? Is it daily cases, the deaths, to say, you know what? We can chill out now with the mask and the distancing. I mean, I know that may be hard to say, but some people want some hope that there's a target we're looking at.
Yeah, the first question is, how do you manage the hospital admissions? Right now, if you're 17 and below, we cannot take care of you. So they automatically go, 18 and below, 18 and below, we cannot take care of you. If you're sick enough and you're 18 and below, you need to be hospitalized. We ship you to UAB, Children's, all those hospitalized that they could manage. They have what we call PICU, or Pediatric Intensive Care Unit, or MICU. We have been talking to our pediatricians about that. Let's say it comes to the point that they're inundated as well. Birmingham is burning up. Atlanta is burning up. Tennessee is burning up. And they say, tough luck. We can't manage our own here. You have to manage that patient. So we have been talking to our pediatricians about that, and they're trying to come up with a plan. Unfortunately, I'm an adult infectious disease. I'm board certified as an adult. I have 1 month rotation with pediatric infectious disease. So that was like 20 years ago. So I'm kind of divulging my age. Our intensive care doctors, the pulmonologists, Dr. Patel, Dr. Ferguson, Dr. Schubert, Dr. Stevens, I'm missing one, Dr. Patel. They're not pediatric ICU physicians. So it's gonna be a struggle. That's why before that thing happens, we're trying to push for vaccination, because school opened 3 days ago or 4 days ago. So those kids are gonna be fine. Majority of them will get sick, but they're not to the point that they need to be hospitalized. But if they do get hospitalized, that's a problem. So we're tweaking and trying to coordinate with Children's and UAB about that, how to manage it. But right now, it's kind of one of those plans that hopefully it doesn't happen. But as you know, hope is not a plan. The answer to the second question is, how do you deal, when do you say, yeah, let's throw this mask away, open the business? The number that you're looking at, which is CDC number, is 10%. So if your infection rate, or positivity rate, I'm sorry, not infection rate is hard to objectify. If your positivity rate in your particular town or place is less than 10%, you might be good. And so far, the only state that has accomplished that is Vermont, because they're close to 80% vaccinated. We're sitting at 33, the whole state of Alabama. So look at this way. About 67% of people that you see at Walmart, they're not vaccinated. So our positivity rate is about 22-23%. 10% is the cutoff.
Short follow-up. That positivity rate, how many days or weeks is that?
I think it's a 7-day rolling period. If you look at the CDC.gov, which I did last night, I think it's a 7-day rolling average.
We have a Facebook question on
Let me just. Yes, ma'am.
As far as the booster goes, do you recommend that we get it as soon as it's approved, or wait for a year after we've gotten the booster?
So the question was booster. How do you go about? I think we're probably gonna go through the tier system again, like we did in January. So the tier 1A, the 65 and above, diabetics, cancer patients. It will be dictated by the supply. The good thing about this, what's happening now, is we're seeing an uptick of people getting vaccinated. As a matter of fact, we currently have 2 patients in the hospital who got sick severe enough that they got hospitalized, but they have gotten 1 dose of either the Pfizer or Moderna. So by definition, they're not fully vaccinated, because you have to have gotten 2 doses and 2 weeks after your second dose to be labeled as fully vaccinated. So we're seeing an uptick of that. So supply might be an issue, but right now it's not an issue right now. But with the booster, it's looking like it's a tier system again. You cannot just, as soon as they say it's good, you cannot just barge in there and say, I need to be vaccinated for ethical reason. You want those, folks, high-risk folks, to get vaccinated first. Facebook.
Could you cover heart complications with the vaccine?
So the heart complication called myocarditis, which is inflammation of the heart muscle, has been reported with the two vaccines, the Pfizer and the J&J. Of these 7 million doses administered during that time, I think about 3 months ago, there were about 125 cases. So that's like 0.0001%. Also, it happened during the enterovirus season. There's particular virus that could cause myocarditis, so we don't know if it's causation or correlation. They're investigating it, but your risk of getting myocarditis is also high if you get COVID. So one of the things that you get is heart damage. So your chances of getting COVID and myocarditis much higher compared to your chances of getting myocarditis from the vaccine.
Is there a vaccine that you recommend over the other?
I don't.
Okay. That's all the questions from Facebook.
Yes, ma'am.
I have a comment and a question. And my comment is, we have a group that takes meals, the COVID staff at RNC, once a week. They have for all
By the way, I was gonna mention that you guys have fed us. I gained about 3 pounds. Yeah, and in behalf of the staff, the nurses that you guys fed, we really thank you for that from the bottom of our heart and our stomach, because you have fed us through. I think by far away, you're the ones consistently giving us. A lot of people, a lot of businesses stopped doing that, but you guys still fed us.
Well,
Thank you.
we don't have the opportunity. There's not much we can do, so that's the least we can do. But we do not have the opportunity, to mingle with the staff. But I know the visiting nurses right to leave. Their salaries are, they make a lot of money. They make good money. And the regular nurses that live here and have families here and carry all kinds of care on their families, finally. You know anything? Y'all, we got that.
Yeah, we have. Kristen could answer that. I'm not involved with HR, but we might have an answer for you. I don't want to speak for the hospital.
It just seems like their first line, and they've got kids at home, husbands, and they worry more about their family than they're worrying about themselves. And it just seems like there ought to be some kind of reward. If it can't be anything else, could be a little money. And my other is a question. I know two young women, 25 and 27, this might be out of your field, who have PCOS and are afraid that the vaccine, they're not quite ready to have children yet, but PCOS supposedly is going to be a deterrent when the time comes. And when they decide to, and they're afraid that the vaccine will make it even harder to have children.
So the question about fertility and reproduction with vaccine has been raised several months ago because there's a blog by somebody who used to work for Pfizer that he was eventually fired 9 years ago. He posted a blog or some kind of screenshot wherein there is a particular protein in placenta called syncytin-1, SYNCYTIN-1. It's a protein that is found in the placenta. It has about 5 amino acid that's similar to the spike glycoprotein 5. We have thousands of amino acids. So it's a stretch to compare that protein from the placenta to the spike protein. So that fear and theory is not born of fact because they're not even related. Case in point, when Pfizer did clinical trial in the UK, Germany, they had 35,000 people, volunteers. Moderna did clinical trials here in the States, exclusively in the States, they had 32,000. Some of them, 6,000 of them on both arms, both clinical trials, were women of reproductive age. And some of them got pregnant and eventually delivered safely babies. So that tells you they're the ones who were involved in clinical trials and they delivered safely.
My is your chances of having a baby, and if you die, that really lowers your opportunity to have
Close
a
to
child.
zero.
Exactly.
Yes, sir.
How can individuals in groups get hesitance on board with getting vaccinated?
So we're, like I've said, we're doing these small groups. I think having some kind of preconceived notion that you're hesitant because you're leaning right or you're leaning left, or because you're staying here or things like that. I think you're gonna alienate them more. So what our approach has been, we ask them, what's the problem? What are your concerns? And you address that in a very scientific and very personal kind of way. So you try to kind of dumb it down, not to the point that you're making them look stupid or not, but or like that, but to the point that you know that it's based on fact. But coming in saying, yeah, because you lean this way politically or that way politically, it's really not the way to open a discussion. We have approached our healthcare workers. We have approached people in the cafeteria, housekeeping, like that, and we have asked them this question: what are your fears? The fear about reproduction, about fertility. The African American people, they have concerns about trust because of the Tuskegee experiment. So we have addressed that as well. It's so fast. Why did it get approved so fast? So we have approached that. So it's individual. You cannot say, yeah, you're vaccine hesitant because you're this. So they have their own specific concern, and if you ask them that question, you have a much better chance of getting them to our fold and getting them vaccinated. Yes, sir.
One of the problems here with misinformation is somebody knows somebody who had whatever, third, fourth hand retelling of something or other. One of the things that came up here within the last couple of days was that there was a family of 5 here locally, that all of whom came down with COVID, all of whom had been vaccinated, 2 of whom wound up dying. And that was sort of taken as, okay, it doesn't matter whether you get vaccinated or not. People who are fully vaccinated are getting COVID and dying. Is there any truth to that?
Yeah, so there is actually a report locally, nationally, all over that people who have gotten fully vaccinated still end up getting sick, and it's true. It happened. Like I've said, the Pfizer is about 96% effective against death and severe illness. Moderna is 94%. J&J is about 86-88%. So they're not 100%. So if you're a betting person, you bet on somebody dying if they're not vaccinated. Statistically speaking, you have higher chances of dying if you're not vaccinated compared to if you are. And there is truth to that. We're not gonna lie, but we're in the middle of pandemic. So it's one of those things that you just have to factor in. Hey, do you really want to gamble? Because right now, if you're unvaccinated, you're playing Russian roulette. Plain and simple.
I just want to take a second to echo Dr. Magadia and saying thank you guys so much for your kindness throughout the year. You guys have been such a blessing to our COVID units, and I want to just take a second to say thank you to Dr. Magadia, taking every night, free lunch, free weekend to go out into the community and talk with people like you. So thank you so much, Dr. Magadia, and thank you guys.
How many of you have learned something tonight? Absolutely. Thank you so much. I feel almost guilty because I know there are all those patients there and you're here talking to us, so that says something about your commitment But thank you so much for enlightening us and giving us some good food for thought, because I've learned a lot of things that I didn't know. A lot of you are new. You've never been here before. We want to stay in touch with you. So there's a sheet that we've passed around. Please don't leave here tonight until we have your name, your email, because we have a wonderful newsletter that goes out, and we can't do it if we don't have your email. So please do that. Secondly, he's been talking about the vaccine, and I'm going to give every one of you one of these flyers. And your job, now that you've been here and you've become educated, next Wednesday, right here, from 3 until 6, we're going to have some RMC nurses giving the COVID vaccine shot. Of course, it's free. This one says we'll have 12 random cash drawings for people who get vaccinated. $1,000 they'll total. We'll have 2 for $200, 2 for $100, and 8 for $50. We'll give each person a little snack or something. You'll have to stay here for 15 minutes like you do after you had your first shot. But there are a lot of people out there with just a little word of encouragement from you would do this. So here are these flyers, and I want every one of you to please take one. And we've got new banners that we just put out today right in front of our sign that faces 202 to remind people. And there's another one right here on Noble Street. We're dead serious about what we're doing here. We're a political organization, and you know that the politicians in Montgomery do an awful lot. Some of them deny things that have ever happened, and others are very much in favor of this. We have Pam Howard as one of our own, and I want Pam just to come say a few words about her race that she's going to be running, just so you know her name. You'll be hearing a whole lot more from her. But she would truly be a friend in Montgomery to all of us. So let's give a hand to Pam Howard.
I almost don't want to talk about my campaign because what we're talking about here tonight is so serious. And we've all seen the effects on our community. We all worry about our kids and our grandkids and our parents and our friends and our neighbors. One of the things I would like to mention, if you follow me on Facebook, you know I post numbers all the time about the COVID statistics. And I was talking to Dr. Magadia, and the numbers that are being put out by the Alabama Department of Health are not current. They're showing 3 deaths this month from COVID here in Calhoun County, and we just learned that there's been 16. I worry that our school systems and our elected officials, if they go by what's posted on the state sites, are making decisions based on incomplete information, and that puts us all at risk. So help spread the news, help tell the facts, help people understand that it's about all of us, it's about our community, it's about moving past this, it's about keeping our schools open and our businesses running and our families able to visit each other. And if we don't have correct information out there, those decisions may be made and putting people at risk. So don't be afraid to talk about COVID. This isn't political. Don't be afraid to, exactly as he said, what are you afraid of? What are your concerns? If I don't have the answer to your question, I'll do the research and I'll get the answer to your question. We are in this together. Now, I am running for the state legislature because I think we need some normal, everyday people from our community working for us, and it's a job that I really want to do. I will tell you I am fundraising this month because it's time to put in my first financial report, so if you can help me, I appreciate that. But know that I'm running because I care. And know that I'm running because I think that we need representation. And I think we need people who aren't afraid to make decisions, who aren't just worried about their next election and aren't just worried about keeping their donors happy. We all need to have our voice in Montgomery. And if any of you are willing to run, there's a whole lot of places open on the ballot. I'm doing it because there's nobody else stepping up and doing it. And if we don't work together, we won't be heard, and we can end up having to live with decisions that aren't the best for us. So if you can support me with that, wonderful. And if you are willing to step up and run for office, please, we'll help you. We'll learn, we'll teach you. That was scary.
That was a wreck.
Do you have a question?
Where can we go to learn more about your policies?
I have my name of my campaign is Elect Pam Howard. My website is electpamhoward.com. My Facebook page is Elect Pam Howard. I'm trying to keep it as simple to keep information out there as possible. I'll be happy to give you a card, and if you want to learn more about it, I'll be happy to talk to you about it. My issues that I'm most concerned about are healthcare, education, jobs, building industry here in Calhoun County, helping things. I miss my son. He had to move away for a good job. I got 4 grandkids growing up here, and I want them to stay here and be happy and have opportunity. I want us all to be able to be successful, and I think that there's a lot that can be done to expand broadband here, to bring in industry, to build the tourism that's coming into the area. So I want to work on those things, and that's why I'm doing what I'm doing.
His follow-up question would be, how can we help?
How can you help? We will talk. I have a good team building, and I look forward to anybody who wants to work with me, and we'll have a lot of fun. So, thank you, everybody. Please, please, please get vaccinated. Talk to your neighbors. Do what we can do to help the staff, and anybody who wants to help us cook the meals. We've been doing it once a week. It's a lot of fun, and it's really rewarding. So get with us on that too. Thank you, Sheila.
Thank you, Pam. Hey, I would invite any of you that haven't, you want to do a walkthrough at the new headquarters of the Calhoun County Democratic headquarters, feel free to do a walkthrough, check it out, because we'll be doing other businesses things here too. So thank you again for coming, and we appreciate all of you, and thank you again to Dr. Magadia and his staff. So you're greatly appreciated, and some of you guys would help with some of these chairs. That would just be the icing on the cake. Thank you.